the conference yesterday and today was there was one group who did the implementation, but the other group really could not reuse that implementation, which I think is one area which open source as a product really attacks. So our thought was that we will be able to start up some concepts in clinical transformation in Max Healthcare, which actually we would be ready to share with the world across, so that this wave of electronic health records maintenance actually starts across, at least in India and other places. So that was the basic thought of really choosing a product which was open source, and we still want to make it really an open source, so we'll be open to even share some of the best practices that we use in our product with everyone once it's implemented.
Dr. Nina, yours is the other hospital that uses data mining a lot. So can I have your experiences on that? You have a different software, isn't it?
So, our data mining is currently limited to actually only financial data mining. Okay, we have really not gone into the clinical data mining. Okay, and I think we're not ready there. The idea of putting the EHR was to be ready, become ready for clinical data mining. We're not there yet, and that's certainly in our vision for next year. In financial data mining, I mean today, if we need to know the profitability of a vertical, say a cardiology vertical or oncology vertical, or even go down to a level of how much, say, revenue a particular doctor is generating, because for our hospitals, every doctor himself is a revenue generation, entity. We can do that, but we possibly haven't reached to a stage where, I mean, we also have data to know how many patients of what age group came in and what were they, what were their kind of, how much was the stay, etc. But I really don't have data today to say what they were diagnosed for, because the diagnosis is still not really in the standard formats yet. We'll surely have by next year. So our vision is actually to come up with a clinical diagnosis, which will tell us how many patients of this age group who actually had this kind of social history and did ABCD were diagnosed with this kind of disease, and when they were actually given this particular medicine and this kind of treatment, how did they improve with that treatment? So that's our vision really, which I am pretty sure we'll be able to manage with the EHR that we are planning.
I just wanted to make a suggestion. We also had this problem. Last year, doctors would come and say, can you please show me the list of typhoid patients who stayed for more than 10 days? And I used to say, yes, I can tell you, I can give you a list of patients who stayed more than 10 days, but I don't have diagnosis typhoid. Then things changed. Doctors started entering the diagnosis, and we started off right on day one with ICD-10 codes. And there was a big hue and cry, and the biggest resistance to EMR implementation in our hospital is the coding. Doctors find it difficult to do coding, but I said, no, you have to do coding. So now you've got 100% of whatever is being entered coded, but only about 50%, 48% of the clinical records are being entered. Those that are entered are fully coded. So we got a brainwave. Starting from the 1st of July, that's 1 month back, we got our medical coding department to post-discharge fill up the codes which were missing. Because they anyway have to do all the coding 100%. I mean, all hospitals are supposed to report to the government coded, ICD-10 coded. So I said, fine, instead of doing it on paper, you do it here, and you only have to do about 52%, because the rest is already done. So they started filling in. Now, from 1st July onwards, we have at least the diagnosis 100% coded. So this month, for the first time, we are submitting to the Government of India the mandatory report of ICD codes from within the HIS. But more important is that today if someone says from 1st July, in the month of July, how many typhoid patients were admitted, who were male and who stayed for more than 25 days, I can give a diagnosis. So my suggestion is that even if the doctors don't do it, rope in your medical records department. This is their job. Doctor's job is to look after patients, isn't it? So they will give that a priority. But medical code can't say, oh, our job is to play solitaire on computers. No, their job is to code, make them code. So you'll have your diagnosis in one go, 100%.
Next, I would like to direct the question for Tim, because he's about to leave. Mr. Tim Ellis. He is whole system LTC demonstrator program manager from Department of Health, United Kingdom. If you could highlight on the innovation and service improvement, what is going on.
Thank you very much. I work for the Department of Health about within our policy area, we look at people with long-term conditions, with chronic conditions, and if we look at hospital utilisation in England and UK, about 5% of the population with multiple long-term conditions account for about 40% of all bed days in hospitals. So what we've been looking at is how we can extend the reach, so we're not just looking at hospital systems, but we're looking at systems that reach into the community and reach into the home, that provide sort of more detailed information on people's status and also enable them to self-care so they understand their condition. We provide advice for them. And so working with our primary care and our secondary care providers, we sort of enable those people who we call revolving door patients who go in and out to live their lives, more independent lives. So there's two things we've done really. We've put devices into people's home that enable them to daily monitor their biometrics. Depending on what condition they have, they take different vital signs, and that's available to both primary care clinicians and to consultants and specialist nurses within the acute sector. And that's introduced some information challenges in terms of governance, in terms of standards, interoperability and integration. But the other thing we've been doing, because the conversation's been heavily focused on data mining, is we extract all community care data, all hospital care data, and we also look at social care data, because in the UK we provide free home care to people who can't afford it when they get too frail or too ill to live independently at home. And we produce a risk stratification. So we say, what is the likelihood of these people coming into hospital in the future? And we use that to target early interventions. So we're taking a preventive approach where we can focus in on the whole population and decide who we're going to intervene with and what interventions we're going to do. And we can do that in consultation with both the primary and acute care physicians. And then for those people who have been diagnosed and we know they have a high likelihood of being a revolving door patient, we put equipment into their own homes to help us, enable us to predict when they're going to have an exacerbation and intervene early before they need hospitalisation. And so that's a win for the system, it's a win for the primary care physicians, and it's also good for the acute sector because it frees up beds for planned activity rather than reactive emergency admissions and things like that. So it's been a challenge, and we're still evaluating the full impact of those, but what it seems to do, it does seem to change utilisation, reduce emergency admissions, but satisfaction levels from the patients are very, very high. Their carers benefit, but also it can change the way that the physicians work, because they work now much more, if you imagine someone who sees a clinician for a few hours or a few days every year, now we have daily information on them. We can make much better clinical decisions, and we can sort of map their care pathways much more effectively. So we think it's a big future for us in terms of long-term conditions policy, and we think it will help us meet the challenge of saving a significant amount of money in the NHS.
Thank you, Tim. Would you like to ask two questions for Tim, because he's about to leave? I'd like to throw it open. He spoke on preventive and predictive health.